Respected Professor Budhwani, Dean Professor Malik, Madam Professor Malik, our academic DDA, Pramod, Roshan, Riaz, members of the fraternity of pediatric surgery and entire AIIMS. What a wonderful experience I've had today this morning to know about the growth of AIIMS Bhopal. It could not have happened unless you have got a very committed team. And one committed team which started off with Madam Malik, as she said, they were very few to start with, but people rallied around her, and it happens only when you have a very strong beginning. So a lot of credit goes to you, Madam, the people who started it off, obviously. Now, pediatric surgery, if you look at what Dr. Pramod mentioned today, about 100 major cases in a month, it also connotes a lot of things. The connotations are that 100 pediatric surgery cases are not, these children are not many adults. They require much more inputs and sustenance. The support that you require from a robust and collaborative, positive pediatric department cannot be underscored any further. So obviously we see the team which is working here with the very able support of the administration and academics headed by Dr. Rajesh Malik. It has all gone into it actually. This is just the tip of the iceberg, and if this glimpse of the Department of Pediatric Surgery has to say anything, I can speak volumes about what overall AIIMS departments would be like. All the state-of-the-art facilities, the installation of urodynamic machine. There have been departments in the country for decades and they have not had it because they have not realized the importance of that, which again puts you on the frontmost pedestal, that you are looking at things which require early management. Madam mentioned very clearly, she very eloquently mentioned 5 cases of CKD. In fact, all of them emerged from congenital neuropathies which are eminently treatable. Besides that, we can diagnose them antenatally, but we sometimes face the wall because they are programmed kidneys which would not do well, but the research goes into it. There have been improvements, and I'll talk about those things which we have done over the years. So with these words, I realized when Dr. Pramod mentioned that we have a foundation day, I remember the journey of this department. Dr. Riaz had joined in 2017, then Pramod and Roshan were selected. I was here at that point of time. I feel so proud that my selection has proved the way, as Dr. Malik very eloquently mentioned about the department and Pramod and his colleagues there. So I thought that since there will be a heterogeneous sort of attendance here, I should not bore you all with specifics about a particular subject where there are many in pediatric surgery. I would rather give you a glimpse of the spectrum and then take you to journey, and particularly I wanted to speak a little more about urodynamic studies because that is being launched, and a lot of youngsters should know when to call for the study, because unless you ask for the study early on the disease, you can't take the best out of it. So with these words, I would begin the talk here. Next please. So pediatric do you have to manage it from this? Okay. So pediatric surgery has a very wide spectrum from head to toe, and each disease comes to us in shades of spectrum. So you look at the conditions, and then there are spectrums in each condition. We primarily deal with structural birth defects, but we also have tumors, and we have got also infections and injuries also. But structural birth defects surgery is the core, and as I said that as we start our careers, gradually we move deeper and deeper. We see a spectrum, we see shade, we see multiple complex anomalies, many conditions. And so I often feel that the practice of pediatric surgery maybe 50 years back has now moved on, as Dr. Malik also mentioned, to the new era because of the knowledge, the information, the experiences that we have gained, so that's the only change is the only constant, and we learn from it. And so if you look at it, the science is not truth, it is the search for truth. What people were doing at that point of time, maybe 50 years ago, they were doing what was available to them. They were offering the best, but the best is yet to come, and this will continue. And so that's why I said that what we do today will change, and we should be open for that change, so that it's the change for the good. Now I often there's a semblance of pediatric surgeon with a scuba diver. A scuba diver would go into the sea, and deeper. As you go deeper and deeper, you see more and more complex anomalies, reconstructions. So you see some kinds of fish, you see even more monster kind of fish and more difficult surgeries, and then you see various kinds, and that experience adds to us. Similarly, in birth defects, we see, now this is a child, aglossia, no tongue. The challenges of operating on a child and giving him a tongue, one can only imagine that. A child with double tongue. See, the spectrum, the shades are so wide and swinging. Without a phallus, a very devastating scenario for a family where you have a child like this, diphallus. See again the spectrum. You see a child with absence of skull. 3/4 of this child's skull was absent. The dura was exposed, the sagittal sinus was exposed. There was very high mortality. We had this baby and there was no case reported of 3/4 skull surviving. That was a child in the ICU. So we did the surgery and we rotated the flaps from hair-bearing areas to the front of the child. Child grew. And now she came in follow-up with large hair. So I'm trying to tell that the spectrum is very wide and the pediatric surgeons are very dexterous, and there are so many things that we do in different areas of pediatric surgery and we import it here. Then you have a child with craniosynostoses. Here there was a child earlier with no skull. Here is a child in which there is a premature ossification in the utero. Ossification should have happened at 30 years of age. Happened in utero, and look at it, has completely gone bizarre as far as the skull shape is concerned. The growth is totally bizarre. Now I'll now tell you how we navigate. As I said, science is not true. We have to keep evolving and what more we can offer. Hypospadias is a very common anomaly. It can come with an isolated anomaly, it can with syndromes like disorders of sex development. There are many surgical techniques because there are variations in hypospadias presentation. And you can do various types of surgery, corti correction, you can take flaps, you can make a very good repair which looks so good. But as many of these children grow, the phallus doesn't grow. And that leads to a scenario when a 17, 18-year-old child will come to you with the parents, and the parents said, this child is doing very well in academics. He went to a college and then ran away from there because as he was changing in the dormitories and locker rooms and bathrooms, he felt so embarrassed that he developed a syndrome which we know as a locker room syndrome. This is an established syndrome, it's a huge psychological problem, it's a real problem, and it happened to one of my patients. When they came to us, there was a very devastating effect on the entire fraternity. We thought that we have done so well in front of surgical impartation, but now this is happening. We looked into the literature, what can be offered to them. And we realized that people give creation of phalluses through various approaches. Now this is an approach for creating a phallus, where you cut thigh muscles, you make tube within the tube, sometimes you take a fibula, leaving behind lot of scars. Major surgery, not everybody can do this surgery, and the end results in long-term follow-up, it all gets disused. They neither work at good urinary conduits nor sexual organs, because this is all vestige. So this is one of the operations which is again very popular, De Castro's, where he takes a flap, brings it down, you can see the phallus on the right side of figure, and take a rectus muscle. This muscle atrophies. So you can take a muscle and make a bulk for the immediate gain and appearance. But it atrophies because it is of no use, it will not be utilized. So when this child came to us and they insisted, I really had to think as to what should do. Dr. Pramod may remember those times. And I didn't know what to do. And therefore we realized that after seeing the literature, we should offer him something which every pediatric surgeon can easily offer. It can sustain the test of time. He grows up and lives his life. So I created this flap. This is an anatomical part where you all know that you can have the superficial circumflex artery in the lower abdomen on both sides. You create a bird wing kind of, flying wing kind of flaps. I brought them down. If you see this part, you can see on this side, and then joined them together. I remember a visitor from Bahrain, that lady was asking, what kind of surgery is this? I said, I'm creating namaste flaps and bringing them down. It was very easy for me to explain to her. And this is very simple. If you look at the scar line, it's not so visible here, I'll come here. This is along the inguinal crease. So the scar is not there. I'm not using any muscles, I'm just creating a scaffold in which we can later on implant a device. So we could create, depending, and we do it around after 15 years of age, so there is enough fat available in the child's abdomen, so that I can create a bulk for it. And so I prefer that. We can create long flaps. I have treated now so many children which go home, and then we do some minor surgical as he grows to create corona as they ask for it, and these are devices you can implant. And this way we are able to offer them a social going on. They go back to school, at least they have got a bulge in the perineum, and so therefore all this happens.